My hearty welcome to all of our Board of Directors and EB members. Hearty welcome to our distinguished speaker, Dr. Shashikala Madam, and all participants who were uh, our all participants to our Indian Academy of Cerebral Palsy first webinar organized in collaboration with SV Nittar Olatpur Cuttack, Government of India, Ministry of Social Justice. IACP plan to organize series of webinars, and this is the first one, and we are not planned this webinar for lockdown season. After lockdown is lifted also, our webinar will not be locked, it will be continued. We will organize the inviting best speakers, best teachers from all over the world to disseminate and foster a learning to all participants. Now we have with us our mentor, Dr. Ashok Johari sir, is a board of director of Indian Academy of Cerebral Palsy and past president of Indian Academy of Cerebral Palsy, is a guiding spirit for us, and he is a director, Enable International Center for Musculoskeletal Pediatric Musculoskeletal Disorders, Mumbai. General of is the editor-in-chief, General Pediatric General, is a president, World Association Against Infection, is a president elect, SICOT, International Society for Orthopedics, and is a director, board of director, Indian Academy of Cerebral Palsy, is a past president, Asia Pacific Pediatric Orthopedics, and is a past president for Asia Pacific Knee Society, and the past president, India Orthopedic Society, Pediatric Orthopedic Society, OSICON, and Indian Academy of Cerebral Palsy and SICOT. Is an honorary fellow, Slovak Orthopedic and Trauma Society. It is my pleasure, and I feel it is privileged and honor to welcome our mentor, Dr. Ashok Johari sir, to inaugurate this first webinar. And over to sir.
Well, thank you very much, Mr. Mallikarjun, for giving me this honor to inaugurate the IACP series of webinars. Well, this is an unprecedented time, and one can say that the time is adverse, but even in unprecedented times like this, in every adversity, it is said that there is an opportunity. And I'm so happy that IACP has taken this opportunity of knowledge dissemination, knowledge transmission from the people who have it to those who don't have, or even a two-way interaction between two different people, teacher and the taught and the teacher, which will go a long way in shaping what is going to happen in the times to come. I'm just reminded of a story. A similar thing happened about 350 years back, to be precise, 1665, was the Black Plague of London, and everything was shut down. They believed in social distancing because treatment was not known. They didn't know what caused it, and we didn't know what was the treatment for it at that time, So this story revolves around Sir Isaac Newton. He was a student. He had just finished his graduation and was a postgraduate student in the college in Cambridge. And because of the lockdown then, he had to go back home, in 1665. He took the opportunity, and all that solitude which he had, that peace of mind he had, not being busy with classes, not being busy with lectures and assignments, sports activity and clubs and everything, He worked on a problem he had started when he was a student at Cambridge, and that led to the discovery of calculus. So such an important side effect of an epidemic at that time. He also worked on light rays, and he got some prisms, and he started passing light through the prism. He made a hole in his roof, in his attic actually. and then put in the prisms to actually study what happened, And from there was born the theory of optics. Same year, he worked on the apple which fell on his head, defined the laws of gravity, felt that, why only an apple should fall from that height of a tree, maybe even the moon can fall. What is the reason the moon doesn't fall onto the earth, So he defined his laws of motion then, and this thing which happened when he was a student, actually, a postgraduate student, locked up in his house in an epidemic with nothing to do. Well, these were all the side effects of that. So as we say, there's always a silver lining. There's always the opportunity in all adversity, and it's the human spirit which takes care of all these obstacles and moves forward. And the IACP webinar is a living example of this. We are moving forward. Despite the fact that we are all locked down, we're all frustrated, nearly 2 months, we're all sitting at home, but that is giving us a time to enrich ourselves, to become better people, mentally, physically, spiritually. I think there's no excuse for not becoming better during this pandemic and the time we are all at home. So we are doing a worthwhile activity, and I'm very happy that Dr. Shashikala has taken the lead. She's a great teacher, a great speaker, a great scientist, a great educator, and a great physician, all that rolled into one, and plus has a beautiful voice. So she was the right person to start the webinar series for IACP. I'm sure she will enlighten you with a lot of things. The topic is also unusual, health and rehabilitation models in the 21st century. This is something I think this pandemic has brought out, as to the social scale of problems, the social scale of involvement of medical people. We all clustered in our clinics, in our hospitals generally, but the pandemic has shown us to think beyond all those, beyond borders, national borders, to think internationally and for the whole world. So a lecture is coming at a very opportune time, where we want to learn these things. So I'm very, very happy, as I said before, to inaugurate this, and it's a great honor personally for me. I would like to declare the webinar is open. Could we do the formalities? Over to you. I must thank everyone involved with these webinars, of course, Mr. Mallikarjun, Saktidas, and the committee which is involved, Asha, Taral, and Meenakshi. Of course, Shashikala Madam, who is here, Dr. Shabina Ahmed, and Divya Karthik, they're all there to enlighten us and to make this sort of very enjoyable, entertaining experience, at the same time, very, very educative and instructional. Thank you very much.
Thank you very much, sir, for gracing the IACP webinar and inaugurating. Thank you very much, sir. Thank you.
Thank you.
So with this very wonderful...
I hearty welcome to Dr. Meenakshi Girish. She is a professor of pediatrics, All India Institute of Medical Sciences, Nagpur, and she is the key person to behind this webinar. She is going to be a moderator for this webinar, and I request her to introduce our distinguished speaker, Dr. Shashikala, and panelist, Dr. Shabina Ahmed and Divya Karthik. Over to Madam Meenakshi.
Thank you very much, Mallikarjun sir. And with this auspicious beginning, I want to start the maiden webinar session today by introducing. She's an extremely experienced person. She's the founder, trustee of Autism Foundation of Assam and chairperson, neurodevelopmental chapter of Indian Academy of Pediatrics. She has a long list of achievements, and I also would like to talk about her along with the next panelist, that is Divya Karthik. So let me introduce Divya Karthik, and then I'll speak about both the panelists. So Divya Karthik is a physiotherapist and program manager at the Association of Persons with Disability based in Bangalore. Now, again, she looks and she is very young, but she has a world of experience in her work. Both the panelists have been chosen not just for their knowledge, but for their remarkable work in the field of disability. I know for a fact that Shabina works with the poorest families. I have gathered from my brief interactions with her whenever I've met her and heard her talk about her work in Assam. I have interacted with Divya also, and I have made my own observations, and I feel that she is the person who walks the talk when it comes to working with the community. Extremely empathetic and the right person to deal with a child with neurodisability. So we are very proud to have these two persons to be panelists for this talk. An unusual topic, as Dr. Johri has said, but I think it's just the right topic to begin a series of webinars related to the Indian Academy of Cerebral Palsy. And the speaker for today befits introduction from a person who can match her stature. And so I invite Dr. Shabina to introduce our speaker for this session. Dr. Shabina, please.
Yes. Thank you, Dr. Meenakshi, for the wonderful introduction and for this invitation. It is with great pleasure I would like to introduce Dr. Shashikala from Sagar Hospital, Bangalore. And she has put in 46 years of service to the medical practice, of which 28 years she has put in developmental medicine. She initiated the formation of developmental neurology as a separate specialty in Nagpur Hospital, where she was working. She served as a research leader in Indian eclectic developmental therapy, and she was a leader in the formation of the IDEA module and started transitional care for developmental disability. She has held various posts, and one of the most important is she is a founder member of the Indian Academy of Cerebral Palsy, and she has been the past president, and she is member editorial board of journal IACP. She has been decorated as an ideal mother by Karnataka government on World Disability Day. She is a parent representative invitee for the National Trust and a very special being, a physician and a parent of a developmental disabled child who has made all efforts to disseminate knowledge and best of care. So with this introduction, I invite Dr. Shashikala to give her deliberations on the topic. Over to Shashikala.
Madam, please unmute your mic.
Okay.
And share your slides.
All right.
It's a great privilege for me to be the opening batsman for this series of webinar. And as Dr. Johri said, it's an honor to me as well as a privilege, and I'm fortunate enough to have a team which has brought our ideas into life today. We're going through bad times, but bad times do bring out the best. And when parents contact us on phone, I know medical care in India, developmental care in India has come a long way. Even a lockdown doesn't prevent us working with our children. So I thank the organizing team for having invited me to this, and I hand over it to Aral to conduct the proceedings, to Meenakshi to conduct the proceedings first.
So, ma'am, we are ready to start your lecture. So if you can share the PowerPoint. and start your lecture right away.
Can I? Meenakshi?
Ma'am, your screen should show your PowerPoint.
Yeah, it is showing.
Now share the screen. Dr. Taral, can you unmute yourself and
Yes,
just
ma'am.
help with the...
Yeah. So you go back to Zoom and share screen. There is a green colored button as we did in the morning. Present button called share screen and then open your PowerPoint.
Hello, Meenakshi. 1 second. The Zoom is not coming up.
Yeah, ma'am, just please close the PowerPoint first. It will come.
Tara, I think she needs to go down to show the control panel. She's not getting the control panel, I think.
Yes, sir.
Yeah, yeah.
She just needs to click at the base.
Yeah,
Yes.
yeah. Just 1 second. 1 second, it went off.
Ma'am, if you get the arrow down,
Yeah, yeah. Share.
the control panel will open up. Then you click to share screen.
Yeah. Got it? Can you see the screen?
Yes, ma'am. Yes.
Make it full screen.
Yeah.
It's okay. Madam, you can start.
Madam, please unmute yourself now.
Can you hear me now?
Yes, ma'am. We are ready to start. Yeah. Go back to the first slide, ma'am.
Yes. Shall I start?
Yes.
Yes. Yeah. We are ready.
Good evening, everybody. It's my privilege to be talking on this wonderful topic today. Health and rehabilitation models redefined in the 21st century. It's a topic which is like a story which will trace all the advances that have happened in the past 70 years, the main events in the field of developmental medicine, from where it started to where it has ended today. We begin with all the most primary concern of all of us health professionals with the definition of health. The WHO definition of health was given in the year 1948. Health is defined as a state of complete physical, mental, and social well-being, and not merely the absence of sickness or disease or infirmity. This was in the year 1948. Even before that, in the early 1900s, rehabilitation was defined. Rehabilitation was started with the criminal scene and subsequently got expanded to medical field, and is defined as a set of interventions needed when a person is experiencing or is likely to experience limitations in everyday functioning due to aging or disease or any health condition, including chronic diseases or disorders, injuries or traumas. Now, this was in the year 1980. We have skipped, almost jumped 30 years ahead. In the year 1980, WHO decided or defined the international classification of diseases, health, and disability. I want you to notice the progression of these terminologies. Diseases came first, health next, and disability later. You all know this model: impairment leading to disabilities, disabilities leading to handicap, handicap exaggerated by the social limitations, dependency, isolation, and all. The physical, social, and psychological factors in the environment were given minimal importance in this definition. But disability was defined as a state or any restriction or inability to resulting from an impairment to perform the activity in the manner or within the range of what is considered as normal for a human being. So the definition of disability started with a comparison to normality, and this was in 1984. Now, where are we now in the 21st century, in the year 2020? In the year 1984, health was again redefined because there was a lot of criticism of the earlier model of health or definition of health, which included the term well-being. What does well-being mean? It can be spiritual, it can be philosophical, it can be physical. So in the year 1984, WHO again modified the definition of health as the extent to which an individual or group is able to realize its aspirations and satisfy needs and to change or cope with the environment. See, environment became important in this definition. Even this is not sufficient because it still doesn't take into consideration the person. The operational definition that is being followed by a lot of people now is what Matchell Huber et al. In the year 2011 proposed, which is not yet ratified by the WHO, is coping, adapting, and managing any impairment. By impairment, we mean change in structure and function. This is a definition which puts person in the center of everything. And subsequently, since ICF and all was formed, disability again was redefined as an experience of limitation or restriction in functional ability. So a new definition came up. What is functional ability? Attributes that enable people to be and to do what they have reason to value, determined by the intrinsic capacity of the person, the environment they inhabit, and the interaction between the two. See, this is an exceptionally good definition because it brings in the person first and the environment next and gives a lot of importance to the interaction between the two. I presume all of us know that rehabilitation is now a part of universal health coverage, a part of the sustainable developmental goals of the WHO for the next millennium. Now, why did this change happen? Why did we move from that morbid definition? When I use the word morbid, I mean It was disease in person. The person never mattered in earlier definition to the present definition where person is put ahead of the disease. Why did it happen? All of you know that science is a very dynamic process. Theories are formed, proved, that again unproved, and newer concepts come up. That's how the monument of science grows, as Professor Ramchandran states it. It's not, developmental science is not an exception to this. From the times of Arnold Gesell, a psychologist, to the present concept of life force health development, developmental science has gone through a lot of changes and lot of perspectives which have made the care of disabled children very, very empathetic and socially relevant. A little before the definition by WHO of health, the redefinition of health, George Engel, a psychiatrist, was the first one to see the battle between the social model proponents and the biomedical model proponents. The biomedical proponents were us, the doctors and health professionals. We believed in the system, the organic system going wrong from the level of the nervous system right up to the subatomic particles. This was the biomedical model. The activists and the social model believers, particularly psychologists, social workers, and parents in particular, believed that the problem was not with the person, but with the environment. So the two were always at the loggerheads. So WHO thought of bridging the two. Even before that, Dr. George Engel, he considered that the way to bridge social model and biomedical model is to bring in the psychological model, give importance to the person. So the term biopsychosocial system was coined. At the same time, we had a lot of perspectives, a lot of developments and newer thought processes. One of that was a principle drawn from dynamic systems theory. It's a principle from thermodynamics proposed by Bernstein in the year 1998 and then taken forward by Telen and others. They introduced a principle called as emergence. It's an extremely fascinating concept. The basic tenet of this proposed theory is that the whole is bigger than the sum total of parts. This is the very basis of developmental assessment. We say reading the forest and not just getting lost in the trees. Okay, so this basic theory constitutes the principle of overcoming constraints. There are three constraints. There are individual constraints, there are task constraints, environmental constraints. Please look at the figure on the left side, the green one. You can see the constraints, individual constraints, structural as well as functional. Lower down in the triangle, you have the task constraints, and then you have the environmental constraints on the right corner. The arrows show you that these three interact and some product comes out of this interaction. To understand this model better, which is basically a mathematical proposition, let us look at the example of movement or mobility. I just put a sort of value so that you understand the concept. Let's say mobility is X. All of you know that mobility needs a lot of subsystems to happen. You have the brain, then you have the bone. The brain gives orders to the muscles, of course, anchored to the bones. So there are two B's. Then you have the muscle, which is driven by the mind. If you don't want to do a job, you will not do it, however much your brain pushes you to do it. So personal motivation is a big factor. So there are two M's, that is the muscle and the mind. So then movement happens in an environment. It becomes refined, graceful, with more experience. Compare the grace of a Bharatanatyam dancer to the harsh walking of a manual laborer. There is so much of difference. The grace comes with practice. Okay, so put all these together, two B's, two M's, and two E's, and think of a mathematical model. The sum total of two E's, two B's, and two M's would be something, but this is much less than what movement brings in and as a whole. No? So X, which represents mobility, is much bigger than two E's, two M's, and two B's. Okay. So you need to concentrate a little on this, and then you will understand, since we're all not very nearer to mathematical concepts, since it was a thermodynamic model, we have to go through this mathematical proposition. Now, this was the year in the 1998. And then in the year 1975, of course, the transactional model of Chandler and Samaroff was started, but it became more important in the year 2000. It's a fantastic model. It says the biology is always against environment. It is not like nature versus nurture. The biology is there, but unless it interacts with the environment, and this is a bidirectional interaction, environment modifies the biology, biology brings in certain changes in the environment. This bidirectional interaction between biology and environment develops a lot of neural functions, which you can see around. Again, these are all bidirectional events. We start with attention, one of the primarily neural functions of the prefrontal cortex. Attention leads to perception. Perception is a part of executive function. Executive function is responsible for self-regulation, and self-regulation is what brings about adaptability. Adaptability drives our cognitive development. These are all bidirectional loops. All of them interact with one another. They influence the other one and get influenced by the other. And you have the outcome of all this is learning. We consider children as products of the environment. A child's behavior is a product of its learning history. This is a very, very important statement. But one of the most defining aspects of this model is learning is only a part of development. It is not the whole of development. For example, motor development, the early motor development is not learned. It is programmed inside the brain. It's an aspect of experience independent development of the neural system. So there are a lot of things in development which are beyond learning. And so transactional model of Chandler and Samaroff, which plays a lot of importance in management of autism in particular, has this to offer to us, that to put the person and the environment not at opposite ends, but at the giving and receiving aspects of being together. Then came in the year 1986, one of the most popular models, the Urie Bronfenbrenner socio-ecological model. You see how the health sciences have drawn psychologists into its fold over a period of time. Urie Bronfenbrenner was a psychologist, and he was particularly observant of the effects of environment on children, like the earlier psychologists, Piaget and Arnold Gesell, etc. The socio-ecological model, the basic tenet of this is development occurs in context. The context can have barriers. Urie Bronfenbrenner was extremely barrier sensitive. He said development occurs only when you overcome these barriers. So he proposed a theory of environment which unfolds in layers or at levels. So we start with the microenvironment, which is the immediate family, and you know the effect of the family on the development of the child. There can be barriers here, maybe less barriers or more barriers depending on the socioeconomic status of the family, parental attitude, so many things. Then comes the meso, that is where peers and teachers influence the development of the child. Then the child moves on to the exo-environmental region, where mass media, counseling, health systems, and all operate. The last one is the macro environment, which is the community and the society, which is driven by ideological cultural norms. Educational policy comes in this level, and that is how mainstreaming and accessibility are two things that are in this domain of macro environment. This is a theory which is followed even today by a lot of special educators, particularly special educators and psychologists. And then came a wonderful model by a pediatrician. I mean, it should fascinate us how from criminal lawyers to pediatricians, concepts have come in this field. It's a fascinating story as I look at it. Wesselton was a pediatrician who was concerned of children's development. The basic principle of Brazelton's touch point model is, and we all know it and we agree with it, no child develops in a linear way. It is not a predictable linear progression. It's a kind of step ladder progression. There are lulls, cases of lull, there are progression, unexpected progression, regression sometimes in a child's development. So when the child progresses, parents are very happy. A child walks much earlier than expected. Parents are thrilled. But the child may not learn to talk for a little longer than what other children do. Maybe because of genetic reasons, parents get worried. And these days, parents are all the time on the internet, get much more worried than other common parents. And they come to you. This was what drove Dr. Brazelton to propose this theory. He said when children are going through these lulls or unexpected progresses, these are the points, touch points where one level meets the other level. And these are the ones which are very, very sensitive to communication. An exuberant parent, because of the progress of the child, needs to be calmed down because the same speed may not occur all along development. Similarly, if a child is in a lull or shows a little aggression, there's nothing to worry as long as we know there are no causes. So this was a model which brought parental communication in a big way to the theories of child development. And of course, came one of the most common and much talked about model of present generation, that is the family-centered approach, which was suggested by many. Even Touchpoint model talks about family development, but Can-Child group under Professor Rosenbaum gave it a definite shape and proposed it and pushed this movement forward. Now look at the family in the center. Let's take the family of a child with a special challenge. They have the burden of care. It depends on the family resilience. The challenge may affect the quality of life of the child as well as of the parents. There are siblings needs the family needs to deal with. Then they need a lot of social support. They seek a lot of information which may be available very easily or may not be available. Then there are parenting styles, parental stress, cultural and spiritual care, decision making. All these things go to make the family-centered model what it is. And one most fascinating work was that of Gerald Edelman, the neuronal group selection theory, which says that the neurons, when during development, have a primary repertoire. When there's an impaired selection in the primary repertoire of neuronal nets, you have obviously a structural problem like cerebral palsy. But when there's an impaired, you see, the brain develops from one cell to the 100 billion cells we have in the adult brain. So you see, they go through so many divisions and so many neuronal groups are formed. When the secondary neuronal repertoire develops, if there is an impaired selection, there are a lot of constraints. If the constraints persist and the impaired selection occurs, you have what are called as the high instance, low severity neurodevelopmental disorders, ADHD, SLD, and autism, which may be submerged in the community, may appear later. But something like cerebral palsy and intellectual disability, they all manifest very early because there is a primary damage in the primary repertoire. And this was by Gerald Edelman, a biologist. See again how many specialties come in. Then putting all this together was again WHO in the year 2001, the wonderful ICF model, which was made simpler. ICF was proposed in 2001 by WHO, and 2012 it was given a common terminology, a simpler terminology which is easy for parents to understand and for doctors to communicate on. Certain terms were introduced, that is, there was in the under ICF categories. Function refers to what people do. Synonyms include role, job, occupation for children. For children, play is their work. Okay, so you understand why play has to be a part of our early intervention. Activity in WHO terms refers to execution of a task or action by an individual. Participation is defined in the WHO ICF as involvement in life situation. New perspectives were capacity is the maximum functioning in an ideal environment that's person at best. Imagine a child in a therapy clinic. Everything is perfect. There's a smooth floor. There's a therapist behind. There are a lot of assistive devices around, support, mother watching over the child works in an ideal environment, he may walk at best. But imagine the same child walking in his daily environment at home. These supports are not there. Mother is not there at the back, or the father or siblings are not there at the back. So does the child walk in the same fearless way as he does in a clinic? No. So this is the performance of the child in the daily environment, which is called as performance, the actual doing in a daily environment. Then came Dr. Amartyasen's concept of capability, is performance as per the capacity in the lived environment. Example is, imagine a child living in a bungalow. Imagine a child living in a first floor apartment. Imagine a child living in a 16th floor apartment, and consider the barriers these three levels have. So what, it may be daily environment, but the lived environment, depending upon what it is, specifically changes a lot of barriers, and it gives opportunity for the child to make a choice, think about it, and motivate itself. Opportunity is also for accessibility to services in this. These are all called as capability sets. Then came the concept of measuring the outcomes of treatment. Now, how do we measure treatment's outcomes? This is important because somebody has to finance our treatment procedures, isn't it? Particularly when majority of health policies are driven by the government. So outcomes of treatment are measured in terms of health-related quality of life, HRQOL, defined as an individual's perceptions of various aspects of their lives that they think are affected by a particular medical condition in its treatment. This was a definition by WHO in the year 2017. Then came disease-specific quality of life instruments. We have CP life, we have epilepsy quality of life, diabetes, hypertension, and so on. And then, of course, is everybody's favorite now, EBM. This was David L. Sackett in the year 1996. All of the treatments have to be proved. There has to be evidence for what I do in my clinic, what I do with my child with cerebral palsy. If I'm practicing Botox, I need to have evidence before I start it. So it starts, this is a pyramid. You see on the left side, there is an arrow mark. The quality of evidence increases as we go to the higher level of this pyramid, and the risk of bias decreases. Higher the risk of bias is higher as we go higher, and is lower as we come down. I'm sorry, the risk of bias is lower as we go higher, because there's greater evidence, the risk of bias is lower, but it's higher. If it is by eminence-based opinion, there is much more risk of bias, higher bias, than when I take on an evidence-based proof like a random controls trial. And then again, in the year 1997, we had the first of the functional classifications, which are a boon to therapists particularly, and of course, orthopedic surgeons and all of us who look for evidence for what we do and how we plan our therapy for special children. 1997, GMFCS was formed. Then came MAX in the year 2007, if I am not wrong. CFCS came later. And then now we had CFCS is communication functional classification system, then eating, drinking, ability classification. Now in the year 2020, we have visual functional classification system. You see the marvel of this system. You tick each of them as per the performance of the child. You have the whole of the functional profile. How easy it is for therapists to have a case management plan with these kinds of assessments. Then, of course, in 2010, community-based model was developed. Towards community-based inclusive development became the goal of WHO. There are CBR goals, there are CBR areas. Goals are health, education, livelihood, social, and empowerment. These are the CBR areas colored in different colors. The concern for us health providers is the blue one, and then for the community-based rehabilitation people is all the red ones. And there are other schools are green, vocational centers are yellow, independent living centers have the purple one, others, that is government, NGOs and business sectors have the pink. Now this is an excellent system. You need to be familiar with the system to understand how it covers all aspects from health to livelihood and vocation. And then came the quality of life. In the year 2009 by again a psychiatrist, Alan Colver from England. Quality of life is an individual's perception of their position in life in spite of health problems. Now, an environment, imagine individual and environment at the two faces of the cube, and they are influenced by culture, standards, and concerns, value systems, and driven by the child's as well as the family's goals and expectations. Last but not the least is LCHT. This takes a lot of time, and I'm trespassing. But in short, LCHD was developed once we thought of fetal or developmental origins of most of the diseases. Most diseases in the modern era have a fetal or developmental origin. This is an extremely important part because for prevention, it all begins where life begins. That is at the preconception phase when obstetricians are involved. Then once there is a special challenge, early intervention comes in. As the child moves to adolescence and adulthood, you have transitional care, and God save our elderly, especially disabled persons. We are yet to build services for the geriatric age group in rehabilitation. Now, life course health development is an emerging biopsychosocial model that conceptualizes health development occurring through transactions between the person and environment over time. Each word in our definitions is important. What drives this is experiences during the whole trajectory, which is very decisive. This was by Haflon et al. In the year 2014. It's a very recent theory. There are two curves here. There's one light blue curve for the high income group and the other one for the dark blue one for the lower income. Just look at the graph and its progression. The child from a high income group has a high social status. There's positive parenting, presuming that high social status is equivalent to positive parenting. Then these children, as they go to adolescence, since they're overprotected, they may develop obesity, but if they have access to care, they can overcome that. Since they all get education, they also have employment, and then they will achieve work-life balance because there's a lot of social support for the high-income groups. Now think of a low social status child coming from a low social status. He has a disadvantage in the beginning. There's late detection. The problems may be manifold because there's inadequate care of the mother because of the low socio-economic status. But when they go to school, the child may be exposed for the first time to positive environment. One of the most beautiful thing about a school is it doesn't differentiate between social status. Schools are same for children of all social status, and so the benefit goes to all children. A lot of, if you have seen the SLC results, a lot of rank holders these days are children from the smaller towns. So that is the beauty. It is a kind of uniform environmental facilitation that happens in school. And then this child, because he also has to work hard compared to the high income group, he is less likely to become obesogenic. And if he has access to healthcare, he may also have education and of course employment. But because of the social, the late early intervention and education opportunities, the child may have job insecurity. So you see how today's concept of health starts from preconception age, goes through transitional care. Don't you think this is wonderful? Yes, I think it's fascinating. Okay. So summarizing, we define health as the extent to which an individual or group is able to realize aspirations and satisfy needs and to change or cope with their environment. And then we discussed biomedical model, we discussed social model, we talked about transactional model in the year 1975-2000. Then we talked about socio-ecological model of Bronfenbrenner. I talked about the neuro-behavioral touchpoint model of Brazelton and Gerald Edelman's neural Darwinism. You know, neural Darwinism, fascinating word. And then we talk about the emergence of George Engel's biopsychosocial model, family-centered model, WHO ICF framework, C bar matrix, lastly, LCHT 2050. Friends, I've been fortunate enough to learn a lot of things from my seniors, and I'm privileged enough to pass it on to my younger colleagues. This is IACP Machines. Let the younger people carry the torch forward, what we got from our seniors. Thank you all very, very much.
Thank you, ma'am. I request Dr. Shabina. Dr. Shabina, please unmute your.
Yeah, I'm unmuted. Can you hear me?
Yes.
Okay. Thank you, Dr. Shashikala, for your wonderful presentation on the change of concepts in the 21st century. Now, I'd just like to summarize what you've said and the understanding from what we get from these changes. Now, it seems that there has been a strong international movement to improve life circumstances through the understanding of the dynamic process of health. So this is one thing, driving force that has helped us to understand the changes. So hence the change has occurred from a diseased person to a person with a disease, as you have rightly mentioned. And this actually pushes us to have a person-centered approach. That is one of the most important approaches in which we try to create an environment for this person and address the needs of this person, and that actually decreases the handicap that the person has in the environment. And the efforts and the ICF classification actually helps us, facilitates this whole process of person-centered approach. Then you talked about the models, the different models that has gone through. Now, the shift in the understanding from a deficit model to a biopsychosocial model, this has been a great process of development. And from here, we can find out that it speaks of a constant interaction of the person with the environment. And all these interactions have become our health determinants and helps us to understand the health disparities that these children of disabilities go through. And if one understands from a total perspective of a total environmental interaction, then we can address the child from a holistic approach. And this is where she said, the whole is better than the parts. Then comes the most important thing that has happened is incorporation of rehabilitation in the universal health system and universal health coverage. I think this supports the socio-ecological model, and it has a very inclusive thought and it helps in the inclusive planning for a rightful citizenship. And this will promote a person to all the health facilities. And in the process to give those facilities, it will encourage understanding and training of developmental disabilities amongst the health professionals. This is one big barrier that needs to be addressed. Then the changes that one has been formulating was basically to see that all efforts are made to provide an ideal environment. And that ideal environment, it would be such that it's going to facilitate the potentialities and a realization of that person, and the capacity of the individual will be known. So this is the environment that we all must get together, and that is the multidisciplinary approach that needs to be addressed. Then she talked about the transitioning, and indeed this is a very, not much thought has been given, though work is going on, the transition from child to adolescence to adulthood. So the child might come up to adolescence, but then thereafter, because of the transition gap, you find that again, there are decrease in the skills. And hence, understanding a child through this whole lifespan approach, this will help us to get a goal-directed planning. It will help us. And again, what is important is in whatever planning we do, that it has to be evidence-based planning. So these were all these developments has also been expressed by Shashikala. And then again, the most understanding to go to the root cause of all these problems is to understand the fetal milieu, the antenatal milieu of the child, and which will help us to prevent, work on the prevention, and then give management in a very methodological pattern. So, and in all this whole management, we find that the family will continue to be a very important context for the child and for the adults. And hence, it is the family empowerment that is most important, because it is there where the window of opportunity of development is there. And hence, our focus should be on family-centered approach. So with this, I would like to hand over to Divya to talk on the family-centered approach and as CBR comments.
Thank you, Sabina ma'am, and thank you, Shashikala ma'am, for that wonderful presentation. And you have given a great insight into various models and also talked about ICF and the importance of family-centered care and the CBR, and also about the functional classification systems. I think it's very interesting to know that all these principles of CBR and ICF and everything is so relatable, is so relevant at this current context. So a parent with a child, or a parent or a family with children with developmental delay and disabilities have got so many queries on their children, and they want to know about the child's condition. So it's our duty, or a therapist, for us to explain to the parent about the prognosis and the developmental trajectories of the child. And I think the functional classification system is a great tool to do so. I think the functional classification, the beauty of the whole system is that it's easy to administer. It can be done in the community settings, even by the community worker. And whenever you are actually putting a level, when you're identifying a level of a child, you will have to have a consensus with the parent or the family in doing so. So by this, actually, the family itself is feeling valued. They're feeling empowered. They feel more responsible towards, the child's development. And when we, as therapists or as practitioners, if we could actually, and we must involve the family right from the assessment in setting realistic goals and helping the family, perform meaningful activities at home to improve the functional ability of the child. Our consent. So the functional classification system itself is so beautiful that it concentrates on what the child can do and not what the child cannot do. And I think this pandemic or this COVID has made all of us realize that, we are not being able to have face-to-face interactions with our children or with our parents in like last 50 days or so. So it actually, we all have to acknowledge the fact, or, realize that the family is the only constant in the child's life, and to empower the family is of utmost important. And when I say empowerment, I don't mean to say the empowerment is only empowerment for a parent, not only on the child's condition, but also on all the aspects of CBR, right? From telling the parent on how they could able to connect the various linkages in the public health system, how they could connect to various social schemes, how they could do livelihood and policy advocacy. And just to summarize that, I think there is definitely an urgent need and an immediate need for all of us to get together. As ma'am said, it could be multidisciplinary or a transdisciplinary approach could be used to and practice and apply all these principles of ICF and family-centered care and functional classification systems in our daily practice. Over to you, Meenakshi ma'am. Thank you.
Yeah, Pooja, thank you so much for Pooja and Shabina for summarizing ma'am's talk. Obviously, it's a very difficult topic, but I think this forms the foundation of whatever we do in the field of neurodisability. I have a few questions from the audience, and one of the questions from Shubhendu is about touch points, Brazelton's touch points. And this question is directed to Dr. Shashikala. And he wants to know, can these touch points occur at any period of development in the lifespan of a child?
They can occur, but they're far more common in the younger age. Younger
Okay.
age group, the touch points are very frequent. They occur almost with the milestones that appear, but they become wider and more infrequent as the child grows older. Again, they become very common in adolescence. This all depends on the parent-child interaction. So there are phases when it occurs, but predominantly it has been addressed to the infant child development, 0 to 6 years.
Okay. There's another question from Anakha Pisharodi, and she has a comment on the graph shown by you on the LCHD model, and she wants to know why there is no regression in the graph of LCHD in older adults. You don't show a regression of the curve there.
A wonderful question. You see, we all have seen this. By definition, most of the neurodevelopmental disorders are, most of the neurodevelopmental disorders have a static lesion. Okay? A lot of progression in a child depends on what the child is as a person. So if a child, even in lower socioeconomic status, does not get the environment that it needs to, if the child is motivated enough, the child overcomes the barriers and develops. Okay? An environment is an addition to the personal traits of the child, which are a part of the genetic inheritance of the child. That's why the graphs do not show you any regression at all. The regression occurs only probably in very severe cases. Or as most of us have seen, most of the children with neurodevelopmental disorders, even from lower socioeconomic status, if they get early intervention benefit, they all progress further.
Ma'am, there's another very interesting statement by Dr. Durga Prasad Mishra, and he says that there are some current research, which suggests that early challenges lead to better adaptive ability later.
Absolutely. 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 I totally agree with that. You see, that's the very theory of dynamic systems theory. See, the constraints are all there to challenge. If you can overcome the challenge, the outcome is much bigger than what you would have expected otherwise. So earlier challenges probably bring out the best in every child. That is what you saw where the high income group is overprotected, they tend to develop obesity. Not the children from lower economic status who have to work hard for their livelihood. Okay, so they are true. Challenges bring out the best even in development early, later.
Okay, thank you very much. Divya, I think I can direct this question to you from Srinidhi Vijay Kumar. She wants you to shed some light on family integrated approach. Would you like to take this question?
Yes, ma'am. Yes. So I think, ma'am, a family integrated approach is very important, because as I said, as mentioned by Professor Peter Rosenbaum, family, there's a research also done. So the family is the only constant in child's life. And given this situation, I would also like to share my own experience. We have been working with family-centered practices and applying ICF and CBR since 2015 in our early intervention projects. And we work with the lowest of the lowest socioeconomic strata group. And by empowering family, by making the family right, like involving the family right from assessment and goal setting, and telling them that they could provide meaningful activities and they could provide enriched environment for the child, what we have noticed is the child have actually progressed, and the progression is seen much earlier, and it's definitely easier to work with a family who's more motivated, who takes the ownership, and we have seen that the children actually progress well than in the families who have no ownership. And so we have actually been getting videos from the parents today, and it's so fascinating, it's so beautiful and overwhelming to see that these children are actually progressing, and there is no, I mean, the whole family is actually bringing the world inside to the child's life. And it's really nice that the family is actually using all the locally available resources to do intervention, and they're equally responsible. And there was also a case where, you know, a mother, she couldn't get, they couldn't have an access to the seizure drugs, so she knew what to do. So that's what is CBR and Empower actually means. So she actually contacted the Indian Red Society, and we ensured that, you know, we could get the medicine right from the district court. We reached at the villages, even at this level, and that's all was initiated by the family. It was not done by us. So I think family centered services is, I think, the future, even be it in the rural or in the urban locality.
So I think that explains the core tenet of family-centered care very beautifully. You did that very beautifully. Pooja from Pune, she actually has a comment which probably Dr. Shashikala can address briefly. She wants to know, why did it take so long for the definition of health to be clarified, and is it still evolving even after 20 years? And why is it that health professionals, doctors and therapists are still not aware of ICF?
Not an easy question to answer, but a very good question either way. So it said that it takes about 10 to 20 years for any fact, any information to come from bench to bedside. So 2001 is ICF, and in 2020, it's just about 20 years. Our curriculum is yet to integrate all this. Unless things are taught at an earlier level, we don't expect every general practitioner, every therapist to keep themselves updating. In our country, the culture is we don't read after we get our jobs and our degrees. So that is why this kind of continuing medical education is important. Once people understand the benefits of ICF, I'm sure it's going to happen in the next few years, and let all IACP members take this oath that we will take it to every nook and corner within our group. That's the only.
Thank you, ma'am. Yeah. Thank you so much. There's one last question, if I have the time. Nidhi Dave wants to know, wants you to shed some light on differences between capacity, performance, and capability within the ICF framework, with an example within the ICF framework.
Yeah.
Can you do that very quickly? We have about, I think, 5 more minutes to go.
See, I told you, the capacity is what the child does in an ideal environment in the clinic, where everything is ideal. Okay? Performance is what the child does day in and day out in the environment. These two come in the ICF model. Capability approach is a totally different one, proposed by Dr. Amar Kisan, and there are followers of capability approach also. It's an offshoot of certain other principles, more philosophical and economical principles from an economist like Dr. Amar Kisan. It talks about the value of decision making and in implementing those decisions at an individual level. So it is individual responsibility that is held up in the capability approach. So a child with living in 16th floor, I told you, has a choice. If the child has a lift and the child can walk down, it is for the child to take the decision. A child who considers walking down the stairs or going up the stairs may consider it as an exercise and can do it. It's his choice in that lived environment. Or a lazy child can prefer to take the lift. Okay, so this is the difference. Capability approach is not part of ICF framework, but yes, capacity and performance are part of nomenclatures which are offshoots of ICF.
And may I add that these terminologies, capacity, performance, and particularly capacity and performance, I think they are important when we, in our daily practice, professional practice, we want to measure the results of our intervention. We have to be very clear what we are measuring. We should, I think, measure performance and not capacity. And to that extent, we should know the difference between capacity and performance. So If there are any questions from the audience, I will come to know. But I would like to just quickly ask Dr. Shabina, can you quickly talk about Madam has touched on community-based rehabilitation, that colored chart that was shown and different colored referring to different organizations or institutions who will provide care to the child. How do you apply this in your individual practice? Suppose a child comes to you in your clinic. How does CBR apply? Shabina.
Well, it's a difficult question that you have said, because generally we don't. But what I would say is that my way of management is a family-centered approach, because whenever from the assessment of the child onwards, I have the whole family with the child, so that from there onwards, we have that every individual in the family understands the problem. And then the participation of the child in the environment improves. So this is probably the beginning of the first concept of a community rehabilitation.
Okay, so the concept of family, yes, Dr. Shashikala, can you?
Yeah, see, the definition of community is a geographical domain in which a group of people live. There's an urban community, there's a rural community, there's a semi-urban community. Community-based rehabilitation basically means you draw the resources within the community. You don't have to send people outside the community. For example, someone comes to me from, say, Bagalkot. I don't have to send the child. I don't have to ask the child to keep coming to Bangalore. I know on a community rehabilitation center in Bagalkot, one of APD centers, I can refer there. So there is now what shall I say, unification of community-based approach to the center-based approach. These are only links in our networking. It's for us to know what the family needs. If the family makes a choice to come back to your center, the urban center, it's their choice. But they say, no, ma'am, I can't travel this much. We must refer them to locally available resources. This is the basic principle of RBSK also. All DEECs, we know other DEECs in the area, and if we know that coming from an area where there's another DEEC, we make it a point to refer to them so that they get continuous treatment. And if the DEEC wants us, most DEECs are almost CBR models only, in the interiors. So they can always come back to us. So this differentiation of models is being lost now. There's a unification, there's networking. So it depends us to know the models and utilize what is good for the family at that particular point of time.
So I think that concept is very clear, that community-based rehabilitation does not mean going to a rural village. The general misconception is a community means a small area in a rural setup. Community means wherever you are, the environment surrounding you becomes a community, and we try to provide services for you within your community. You don't have to step out of your community. Is that right?
Yeah, it's absolutely right. For example, if a child needs school services, I am, as the developmentalist, I'm bound to know which is the nearest school that's accessible to this child. I know the limitations of the child. I know, and we, in fact, make this provision in the medico-social worker calls up the school and gets an entry admission to the child in that particular school. And whenever the school needs our help, they contact us. So as I said, community-based services are a linking up of services available in the geographic area around, not urban or rural.
So this is very relevant to a country like ours, where you may not have a tertiary level care at every place, and a child with neurodisability need not always be deprived of care just because a tertiary tertiary level service is not available nearby, and whoever health professional is managing the child becomes the nodal center to recruit community-based rehabilitation, right? That person will be responsible to make sure that the nearby schools understand the needs of the child who is this professional's patient. The nearby the governmental agency provides the right benefits to this child. So the nodal person is the person who's taking care of that child, be it a therapist or a pediatrician or a neurologist. That person activates community-based rehabilitation within that child's community. So this is a very important concept for, I think, everybody to get across, and this, I think, should be the final message of today's webinar, where we talked about various models of care to a child with disability, and we talked about the earliest model, that is the biomedical model, to the latest model, which I think replaces even the biopsychosocial model, which is the life course health development model, LCHD. Which is slightly difficult. You have introduced the concept very beautifully, but I think it takes some more time for people to understand what this model really is, which will help in providing preventive care to a child with neurodisability. I think if there are any comments from the panel or from the people who are logged in, they can make any comments, or we can call this.
Yes, Meenakshi.
Yes.
May I just add to that window period that one of them had asked about the window period. So the window period is as early as possible, and between 9 months to 15 months, that's a very good period where we can take the opportunity of development. And so we should not miss that. And generally what happens, if you talk of to label anything, it is beyond 2 years. Cerebral palsy is beyond 2 years. Autism is beyond 3 years. SLD is beyond 6 to 7 years. Hyperactivity is beyond 6 to 7 years. But at that, actually, we have missed the window period in the process of diagnosis. So we have to keep our mind that the first 1,000 days of life is one of the most important period of a person's life, and all our efforts should be diverted to this period.
May I ask Dr. Sunanda Madam to just quickly talk on that CBR, if she is online. Dr. Sunanda.
Dr. Sunanda Kohli, are you there? Yeah, she's logged in, but she's muted. Yeah, now she's there.
Hello. Yes. It's been a wonderful talk, and I've been following the discussion. I think a lot has been said about different models, and in fact, the last, even Dr. Shabina Ahmed spoke about the window of opportunity. I fully agree. When we're talking about family-centered services and CBR and community-based rehabilitation, there is always this confusion about whether we're talking about a model or a setting. Now, CBR is actually talking about setting, where we're talking about rehabilitation in the community. However, I think as Dr. Shashikala explained well, she was talking about this model in terms of CBR metrics. When we are saying CBR matrix, it means that there is community-based rehabilitation happening in a framework where you're talking about health, education, livelihood, social, all these with a life coach approach. And this is actually not really seen in compartments. I would say that if I'm a pediatrician working with health as a priority, basically I'm using this matrix to focus on health, but I need to look at the whole child in the context of the family and the community. So what does this child need beyond the health and the immediate rehabilitation that we're looking at? Then means invariably that we're looking at the education of this child, we're looking at building the capabilities, we're looking at giving the child the opportunities. And that's where in a setting we can do much more. In a way, when this was envisaged, it was for rehabilitation, it was actually considered to be something like rehabilitation in a primary care approach, primary care setting, because we do have the secondary and tertiary levels. So I think we should be careful not to confuse the setting in the community, which is community-based rehabilitation, and the model, which is working for CBR within a matrix or a framework. The framework actually gives us opportunity to work across different needs of the child and the growing child through adolescence and with a lifespan approach. This is what I would like to just say now. Thank you.
Thank you, Dr. Sunanda. That was wonderful clarification, and it was a, I think, very opportune time for you to clarify between matrix and framework. And I think the discussion that we had and the overall talk was something that no one would have found in a textbook. So this was an extremely enlightening talk and enlightening conversation and clarifications. I would like to remind all the audience to definitely fill the feedback form, which is available on the YouTube. The link is also given there. We would be happy because this is our very first program, and many such difficult topics would be decoded by national and international experts in subsequent webinars of the IACP. With this, I would like to hand over the mic to Dr. Saksidas to declare this particular session closed. Dr. Saksidas.
Good evening. It is my pleasure to convey my thanks to the our participants and all our speakers. This is the first seminar of Indian Academy of Cerebral Palsy webinar, and also the first webinar of the SB Nirtar. So on behalf of the Indian Academy of Cerebral Palsy executive body, and also from as the director of the SB Nirtar, I convey my thanks to all of you. My heartfelt thanks to Dr. Sasikala. She is an excellent teacher. She has simplified the topic for the benefit of all the participants. We will almost have around 200 participants in this seminar following this link. And also, I thank Professor Johri for his inaugural speech. In spite of busy schedule, he has joined with us, and with us, he's always our co-sir, he's with us. And I thank our Professor Minakshi to be the moderator of this webinar. And again, I thank the Dr. Sabina and Dr. Divya for their as a panelist and well managing the show. And my heartfelt thanks again goes to the team of our technical experts, which has been helped by Dr. Taral Nagara, Asa Chitnis, Dr. Madhavi, and Sanket. Without their help, it is not possible to manage this webinar. And also this YouTube link, also this technical expertise has been done by this all team. My cordial thanks to all of them. And again, without the participants, it cannot be successful. So I again thank all the participants joining in large numbers in this important this first webinar. And we are planning also to have another webinar on 23rd of this month. We will convey you the speaker and the topic and date of time in due course of time. Again, I thank you all for joining us with this seminar. Thank you very much.